The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr. David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, a doctor's deceit.
We've got a likely fraudulent behaviour on behalf of the doctor.
That's Dr Simon Fraser, Senior Medical Advisor at Medibank and a board member on a Victorian Regional Health Service. Simon is also a paediatrician, and I'm presenting him with a difficult scenario.
I would stand them down immediately.
In today's scenario, a hospital has been desperately trying to recruit another gynecologist. A young doctor who grew up locally and has recently returned from working overseas applies for the position. They have general registration with APRA but claim they have extensive experience and training in gynecology and that they recently completed a 12-month attachment at a prestigious US women's hospital. You employ them as a career medical officer with privileges in gynecology for an initial period of 6 months. 2 weeks after they start working, the theatre unit manager raises concerns that although very confident, they do not appear to be familiar with routine gynecological procedures. You ask for references from the US hospital and discover that they worked there for 6 weeks as a final year medical student about 5 years ago. We have a situation where a doctor has clearly lied about their experience and qualifications. I started by asking Dr. Fraser what issues this scenario raises.
There are a number of issues that are addressed here. The first and foremost is patient safety, and particularly as to whether any patients have been harmed because of this. There are issues here around recruitment processes, including a failure of credentialing. We've got potential likely fraudulent behaviour on behalf of the doctor. Now, we've already got evidence of one threat of dishonesty, and it's very important that we understand the breadth and depth of that. It's likely that we're going to need to undertake an audit of his cases and a look back, and this will require time and resources. If it becomes clear that there's any patient harm or potential harm, then we will need to recall patients and undertake open disclosure. And it's quite likely that this will cause significant reputational damage to the organisation and media involvement.
Well, that's a lot of issues. Let's tease them out and go through some of them in a little more detail. So what's the immediate action that you're going to have to take?
I need to organise to meet with the doctor in question as a matter of urgency. In doing so, indicating to them as to why and what my concerns are, and certainly allow, encourage, recommend that they have a support person. At the moment, it seems likely that we have a doctor who is working well outside their actual personal scope of experience, and I would stand them down immediately, at least from their current scope of practice, in other words, privileges in gynecology. This would likely mean curtailing any current active clinical involvement that they have in that role, which might include outpatients, theatre, on-call, and organising backfill. In other words, to ensure that we don't potentially cause any ongoing harm Given that I would likely stand them down, it would be pending investigation and on full pay. I'm assuming they'll be salaried if they are employed by the organisation. It's very important that I notify up, so my CEO or general manager, and this issue is serious enough that the board would need to be notified by the CEO. And assuming that we have a media advisor or a media liaison, I'd be briefing them.
So the risk is they've been working at your hospital for 2 weeks and they've treated a number of patients. They may well not be qualified to treat those patients. How do you go about determining whether or not the patients that they've seen have received appropriate medical care?
Yes, that comes back to whatever their clinical scope of practice has been. The scenario here suggests that they've got privileges in gynecology, and it's not clear whether that's practicing as an independent clinician, in other words, with no supervision from above. And I'll come back to that in a moment. But I need to very quickly understand where they've been working in the field of gynecology, in what capacity, and which patients they've treated. As indicated earlier, it's likely that they may have been doing some outpatient work. We certainly know that they have been operating because of the way this has come to our attention. And they may very well have been on call and provided some on-call care and advice. Having done that, that will then allow us to determine which patients they've seen and in what context. If they have been providing care without any direct supervision, then that raises the ante. If they've been functioning, I know it says as a career medical officer, but say at a senior registrar or fellow level, with some support and supervision, that would be helpful to know.
So if they've been prescribing medications in outpatients or something like that and seem to have been working appropriately, do you need to tell patients that there is a concern that the doctor they saw wasn't qualified?
I believe we need to, David. If the care that's been provided by the doctor is outside the scope of practice as to what we have employed them for, I think we have a responsibility to advise our patients about that, yes.
All right, that of course raises a number of further questions that those patients may well be very upset and raise media issues, and you've already talked about briefing your media team about the prospect that this would leak into the public. As we've seen in several cases recently, these are very topical issues for the media to pick up on. How do you go about managing that?
Yes, I think it's important to be proactive. As I've indicated earlier, I already would have notified our media team, media liaison, depending on the size of our organisation. I think it's important that we look at developing a holding statement. In this sort of circumstance, it doesn't do any good to say no comment. So the bare bones of what I'd be saying to the media is that we have a serious issue here. Patient safety is a priority, and we are undertaking a process to review the patient care. The doctor has been stood down on full pay whilst we investigate further.
Simon, this is a clear failure of the credentialing process, as you mentioned. What are the steps that you would expect to see in a credentialing process at your hospital that would stop this scenario occurring?
David, I think this scenario suggests to me that our processes are either not contemporary or well developed and or have not been followed. In this particular scenario, as far as what I would like to see done and what I would like to have reviewed is there's two components here. One is the process that's undertaken to get us to the point of actually offering and making an offer and appointing a doctor. And then there's the process of checking credentials. Now, sometimes there's a tendency to advertise, recruit, interview, appoint, and then do the credentialing after. And I think there are a number of components here that should be done before. I think, particularly in this scenario, an internet search of the doctor in question would be helpful. I would be, given that he is APRA registered, at least with general registration, I'd be reviewing his registration, particularly seeing if there's any notifications or restrictions. I think in this particular case, I'm assuming that reference checking was not done before the appointment, and I think it clearly should have been, especially from where he has alleged that he's obtained 12 months' experience. Police checking is important, particularly in this case, an international police check, 100-point ID. He may or may not be involved with the RANSCOG. I suspect he may not be, given that he's been appointed as a career medical officer. But I'm interested in his level of training, evidence of that, CV. And then, look, there'll be other minor points of credentialing that may vary from jurisdiction to jurisdiction.
You're very short of medical staff. He has been employed as a career medical officer. Given that he's falsified information, would you look at continuing his employment in more general areas?
It's a very good question and does raise some issues. I guess my thought there, David, is possibly, but I'm very cognizant that we've had a significant breach of trust here. I wouldn't immediately redeploy him because I really want to know more about his level of experience. Are there any other areas of his training or experience that he's told us about that are not correct? So I really need to be very clear about that. Just moving tangentially here, the doctor in question has been given privileges in gynecology. In the scenario, we don't have a gender provided, but that probably doesn't matter. It's possible here that we've even had some issues in relation to sexual misconduct. And one of the things that I'd be exploring is, have there been circumstances where the doctor in question has undertaken gynecological examinations without a chaperone? So I think it's quite a complex question. If we do offer him alternative employment, it would have to be in his confirmed credentials and he would have to be very closely supervised. But it's very important that we follow procedural fairness and natural justice in coming to that point. The other point I'd make in relation to this question is, if we don't offer alternative employment, they've been in the job for 2 weeks, I think you've said, or maybe 6 weeks. They're on a 12-month contract. They may very well have a probationary clause that allows us to terminate their employment. If I did offer alternative employment, it would have to be after thorough investigation and under very careful circumstances. If we do that, that in itself carries risks, not necessarily for patients, because I think we're being careful about it, but there may be media risks in doing that. But we've also got to do what is fair and reasonable for this doctor.
You quite rightly raised the risk of inappropriate practice, particularly in the area of gynecology. How do you go about determining whether or not the doctor's approach to patients was safe in a gynecological context?
I think I alluded to, we're going to need to determine all cases and circumstances where the doctor in question has been acting within the scope of gynecology, in this case outside their level of experience, as well as clarifying whether there have been or any circumstances where they've been practicing unsupervised. Having done that, I would organise an external review by an external experienced gynecologist to review the cases and the outcomes.
All right. How would you go about determining or engaging that external person? Where would they come from?
There's a number of options that we could look at. The scenario here doesn't indicate what size of hospital we are or where we are, but assuming that we've got workforce shortages, it's likely that we're probably in a regional or rural setting. I'd look at a tertiary, quaternary health service in my state. State of Victoria, I might see if I can get an expert through Safer Care Victoria or the relevant authority in other states. One might even approach RANSCOG.
Are you going to tell AHPRA about this doctor's behaviour?
Yes, if it's become clear, and I mean, we've got an allegation here. Well, no, we don't have an allegation here. There's concerns from the nurse unit manager that they are underqualified, but we've uncovered here that we've got a doctor who has lied to us in terms of their level of experience. If that's clear, which it seems to be in the scenario, then I would notify AHPRA, because I think this would fall into the category of a significant departure from accepted professional standards. Now, I don't take that component of mandatory reporting as necessarily a departure from accepted clinical standards. It's accepted professional standards. And I don't think anybody would argue that it's professional to lie about your credentials. So, yes, I'd report to AHPRA. If it becomes clear that there's maybe some sexual misconduct as well, that's a separate mandatory report.
What about reporting to the police? Does lying to your employer constitute sufficient evidence to raise a criminal behaviour complaint to the police?
In my opinion, yes. There has been dishonesty here that may or may not have resulted in patient harm. I think this is a potential criminal matter. And I would probably seek legal advice on that. But I think any legal action against a doctor here, if this is criminal behaviour, should be a matter for the police and go through the courts through that process.
It's a significant impost on the hospital, but it may be necessary to protect future patients from this doctor's actions.
Yep.
What are you going to do in your hospital to make sure this doesn't happen again?
I think we need to ensure that we provide a safe and effective gynecology service. So before we do that, I've already talked about credentialing, but we need to review our recruitment and credentialing processes as outlined in my earlier responses and ensure that they're as watertight as possible and that all the I's are dotted and T's are crossed. I think the broader issue here is we do have workforce shortage in gynecology and we'll need to look at ways of addressing that. I think we need to ensure that we've got appropriate training pathways and that would involve RANSCOG. For our current and future gynecology staff, we need to make sure that we've got appropriate processes for continuing professional development, performance review. We need to make sure we've got transparent processes for incident and complaint management, case review processes including M&Ms, benchmarking excluding external, and I think very importantly understanding what the hospital's capability is or should be and where there are gaps, making sure that they're addressed.
Clinical governance is all about culture. And in an organisation like this, a scenario that undermines the trust in medical leadership when this sort of thing happens, that a doctor is employed who isn't qualified to do the job they've been given. Can you talk to us about re-establishing, the trust in the medical process and clinical governance amongst staff?
Well, that is a good question. I guess it in part depends on where the clinical governance or credentialing process has fallen down. I think it's very important to demonstrate to the medical staff that there has been a significant error here, at least from a medical leadership point of view, that we take full responsibility for that this is an opportunity to do a thorough review of our processes and to learn from them and improve them. That will take time. But that's a very good way of demonstrating that medical administrators or senior executives, hospital clinical governance processes are fallible as well, and that we learn by our mistakes and improve them. But that'll take time. It would be inappropriate and unfortunate if we don't handle or deal with this well, because that doesn't send a good message to the medical staff.
I absolutely agree. Yeah. You have to eat humble pie on this one.
Oh, definitely. And it's possible here that, it doesn't say how long I've been the medical administrator for, but if I have been for some time, this has happened on my watch and I have to take responsibility for that.
Thank you, Simon. Unfortunately, not an unknown scenario as we've seen in recent media events. Do you have any final thoughts or observations on this scenario?
Yeah, thoughts here is, what should their scope of practice be, even if they had 12 months of training overseas? So, we've got a doctor here who says they've been trained in a high-quality US hospital. I would have thought perhaps that they would still need to be supervised and at least have partial accreditation with the college. I think it's very important that we acknowledge and applaud the theatre NUM for bringing this to our attention. But in doing so, he or she has whistleblowed, and we need to support that. And I think it's very important to involve the Director of Nursing early in this piece. We still have a gynecology workforce shortage, which may be even harder to recruit to in the medium term because of the reputational damage that's done here. I think my responses to the questions and management will depend to a degree on the size and location of the hospital. The other point I think it's really important here, David, is we don't know about the psyche or what's driven this doctor to lie to us or the extent of their lies or the reason behind that. Now, this might be the first time they've done this. It may not be. So I think one of the things we haven't covered is it's very important that we support them during this process. They are an employee of ours. I mentioned having a support person at my early interview and discussion with them. Whatever transpires in the coming weeks and months is serious for this doctor. It's quite possible that with the flux of time that they could be deregistered. And I would be, as much as I can, I'd be concerned and would be wanting to ensure that their own mental health is being supported as well. I think we've got a responsibility to do that, even though they've been, terribly naughty and dishonest.
It's a very good point that we mustn't lose sight of the fact that they are a person.
That's right.
That was Dr Simon Fraser, a private paediatrician who is also Senior Medical Advisor at Medibank and a board member on a Victorian Regional Health Service. And that brings us to the end of this episode of Safeguarding Healthcare. I'm Dr David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.